speaker is Dr. Michael Bresler. And my screen froze. Can you guys hear me?
Yes.
Okay. Dr. Bresler is a professor of emergency medicine. He's a well-known educator. He lectured nationally and internationally, has numerous publications, textbooks, text chapters, journal articles. He edited the cardiovascular textbook of ACEP, as well as the textbook on emergency cardiovascular care and CPR by the AHA and ACEP. Interestingly, he also has written the California and federal healthcare legislation and testified frequently on healthcare issues considered by the U.S. Congress or the United States Congress. He has won many awards, served as Speaker of the National Council of ACEP, President of the California chapter. ACEP designated him as a hero of emergency medicine and a life fellow of the college. I am super interested to hear what he has about ACS and to learn more about him. Welcome, Dr. Bresler.
Well, thank you. Appreciate that. Let me share my screen here and let's get started. Okay, so what we're going to be doing now is talking about risk management and evaluation of chest pain patients, but particularly those with acute coronary syndrome. Now, I have no conflicts of interest. I'm pure. Shouldn't be any problem with that for today. Now, also, this is not a talk on evaluating chest pain in the emergency department per se. It's a talk on how we avoid getting sued. That is, risk management on this issue. Now, more important than any legal thing, of course, is giving good patient care. That's what it's about. But while we're at that, hey, might as well not get sued. So what we're going to discuss then is first the scope of the problem, difficulties we can run into that might lead to litigation in terms of taking our history, doing our exam, just a little bit on ECG, cardiac markers, differential diagnosis, documentation, communication with the patient and family, and then what do we do with the patient? First, the scope of the problem. Well, a survey by the largest independent group of insurance companies that insures about 15, that has 15 participating insurance companies with a very large database, showed some interesting things in terms of our specialty. Now, their database goes back to about 15 years before the turn of the century, but we're just going to look at the criteria, or rather the data from 2001 to 2015. And these are closed cases, and of those, about 5% originated in the emergency department, and maybe another 1% in urgent care centers. And about 27% of those closed cases actually resulted in payment, which is larger than in general one might have expected. The most significant diagnosis in the closed cases was cardiac or cardiopulmonary arrest. As you can see, MI, aortic aneurysm, pulmonary embolism, the things that we're discussing today were quite frequent in terms of final diagnosis that ended up in litigation. Now, I tried to find from their database the more relevant data which would relate to the chief complaint, that is what the patient was complaining of on presentation, because that's what we deal with in the ED, of course. But what I could find was their final diagnosis, and it parallels to some extent. Now, the main problem for emergency medicine litigation in the 6,000 cases that they reported was failure to diagnose. In fact, treatment of chest pain patients was really not often a factor at all. And acute MI had the highest likelihood of payment, and look at that, it's a little bit under 50%. So you miss an MI or something that turns out to be an MI, got a pretty good chance of either settling or losing that case. Now, just a few things, at least in the United States, this is civil litigation. It's not criminal, not going to go to jail because of this. You won't lose money either. The insurance company is at risk for losing money, but generally not you. Very rare that the attorneys will go beyond your limits of insurance. 3 requirements for a finding of malpractice: there has to be a violation of the standard of care, there has to be harm to the patient, and there has to be what's called proximate causation. That is, what you did or didn't do results in that harm to the patient. And the standard of care can vary from state to state and perhaps nationally as well. We have an international audience today. But basically, it's the care that should be rendered by a reasonably prudent physician under the same or similar circumstances. Litigation can go on for years. 3 to 5 years is not atypical. It's a horrible process, high divorce rate among doctors being sued. Now, you can pray, that you won't get sued, and that may well help a bit, but obviously ain't going to be sufficient. So the better thing is just don't get sued in the first place. And the main way to do that is give good patient care. But there are some other things as well. Good charting, good communication with the patient and with the family. Remember, if the patient dies, they're not going to sue you. It's the family. So I'm not going to present specific cases per se, but I am going to use some wording that was attributed either to doctors and or the patients. These are words that appeared in deposition or trial testimony that the plaintiff said were verbalized by the doctor and or the patient. So let's look at history first. The doctor comes up to the patient after evaluation and says, hey, I got good news for you. Your ECG and your labs are all normal. You've had chest pain for 6 hours. This isn't your heart. And the patient, of course, wow. What did the patient say later? Well, the doctor gave me a clean bill of health. Now, I don't know about you. I have never heard a doctor use the term clean bill of health. But we have so many patients say that in depositions. The doctor gave me a clean bill of health. But we're not saying that at all. But that's the interpretation. Now, most patients presenting to the emergency department with acute ischemia, of course, are not acutely infarcting at that point in time. They have a non-diagnostic ECG, non-diagnostic cardiac markers, at least at first. And so the most important diagnostic modality is the history. And where we see screw-ups in litigation is usually because we messed up our history taking. Now, we know that, at least it's thought, although there's some controversy, that symptoms may be more likely to be nonspecific in the elderly and in women. The recent data really calls that into question, but anyone can just be weak and dizzy, and yet that's an MI or unstable angina. Denial of chest pain is something occasionally we see. We doctors consider pain to be anything, pressure, burning, whatever, but patients may deny chest pain when they have some other symptoms. So probably better to say chest symptoms when we're discussing it with the patient. Now, the quality of the pain can be anything. Cardiac pain can be pressure, burning, sharp, dull, pleuritic. But one of the common pitfalls that we see, and we've reviewed hundreds of cases now over the years, how many times have we gone up to the patient and said, well, when did your pain begin? Or when did your chest symptoms begin? That's not what we want to know. That's not the question to ask. We want to know other things. When did the entire set of symptoms begin? Maybe 2 days ago, maybe 6 hours ago. If it's intermittent, when did this particular episode, are you having pain right now? When did it begin? When was the last time you had no symptoms? Was it an hour ago? Was it 2 days ago? What's the longest episode of pain when you had it if it's episodic, and what's the shortest episode of pain? If there's a non-diagnostic ECG and negative markers, and the chest pain has been there for 6 continuous hours, that's not likely to be cardiac. On the other hand, if the patient says, like in this case, well, I've had pain for 6 hours, and those markers, those in EKG are negative, but the pain lasted only 20 minutes each time, yeah, that could definitely be cardiac. So we have to be careful, be aware of that. We're not going to miss a STEMI, but we may miss unstable angina. Pain is resolved. ECG is non-diagnostic. Markers may be normal, at least at first. Now we're going to discuss high sensitive troponin and how that may change things for the better, both for our patients and ourselves. We'll get to that later. So in the history, what's important is, I'm sorry, let me back up just a moment here. Okay. All right. Sometimes the patient can complain of pain with breathing. The important thing is that we want to know something else. So a common error that we see in litigation is the doctor will ask the patient, do you have pain when you breathe? And the patient says, yes. And the doctor said, well, deposition, the patient testified that the doctor said, hey, can't be your heart. Well, pleuritic chest pain is a very common co-founder that has resulted in litigation and missed ACS. And what is pleuritic chest pain? It just means pain with breathing. That's not what you want to know. If the patient has pain with breathing, there's another important question, and that is, does it hurt between breaths? Now, sometimes when I've asked the patient that, they said, hey, what do you mean? If I stop breathing, I'm dead. No. This is what I do. All right, so take a deep breath. Let it out. Stop. Freeze. Don't breathe. Do you have pain right now? And so if the patient doesn't understand you, that's if they have pleuritic chest pain, that's an extremely important thing. Does it hurt between breaths? Pleuritic just means hurts when they breathe. And a pleural-based process is going to hurt likely when they breathe and probably not between breaths, but a non-pleural-based process is always going to hurt between the breaths as well. And of course, that is cardiac pain. Associated symptoms, can be anything: dizziness, dyspnea, palpitations, nausea. In fact, that may be the only symptom that the patient has. But especially beware of diaphoresis, because studies have shown that a patient that has diaphoresis is more likely to have a coronary artery related disorder than any of these others. But of course, any of them can occur, and any of them can occur without chest pain in acute ACS. How about radiation of pain? Well, crushing substernal chest pain going down the left arm. Hey, everybody knows what that is. Could be isolated left arm pain, could be both sides. And of course, then we have to be concerned, and that kind of thing is this dissection. It could be just the right arm, rarely, but it occurs. Another problem that we see in litigation is isolated jaw pain or a toothache without chest pain. Again, referred pain just to this area. Okay, maybe it's TMJ pain, maybe it's a toothache, whatever, but be aware of that. Now, back pain, think back pain, we're gonna, cross our minds, this could be a dissection, of course, but sometimes we see just isolated back pain in MI. It's rare, but it does happen, or pain in the chest going to the back. Again, we'll discuss aortic dissection a little bit later. Obviously, we've had an excellent talk earlier today on that, but be aware that either of these can mimic the other disorder. And obviously, we don't want to go squirt an anticoagulant or fibrinolysis a patient with dissection. How about the exam? What are some of the problems we can run into with the exam? Well, there are several that we see in litigation. Patient testified, well, the doctor pressed on my chest and asked me, did it hurt? And we pressed on the chest. And the patient said, yeah, it hurts. Ow, doc, that hurts. And the doctor said, well, good. Well, obviously, this is your chest wall. Maybe you have some inflammation in your cartilage. Can't be your heart. Wrong. Be aware of how big you are and how frail that patient is. A lot of times, when we press on the chest, we're hurting people. That may or may not be the cause of their pain. So if that is the case, you want to go further. If there's tenderness to palpation, ask the patient, does this exactly reproduce? Is this what you're complaining of? Is this the kind of pain? Doctor said, no, it's not quite. All right. Be aware of how hard you press and how big you are and how frail the patient may be. Does it hurt with truncal motion and moving, the shoulders around and chest? Well, maybe that increases the chance that it could be a little cartilage inflammation or something, but again, you can't count on that kind of thing. Antacids, a real common problem. When we look at litigation involving ACS, it's not at all uncommon that the doctor will have given the patient an antacid. Doc comes back later, hey, did that help? Yeah, I feel a lot better, doc. Well, can we rely on that? Of course not. The response to GI cocktail, a lot of docs will say, don't use it. Just don't give them a GI cocktail. Others will say, yeah, but be careful. What you want to know is if you give a GI cocktail with whatever's in it, antacid, lidocaine, whatever, that if the pain is relieved in 1 or 2 minutes, maybe that points somewhat toward GI. But if you, let's say, order this, you type in the order for the antacid, 10 minutes later, the nurse gives it, you come in a half hour later, hey, that antacid help? Patient now feels fine because it's unstable angina and the pain's gone away. And say, yeah, that helped. That can lead you down the wrong path. No, that's not what you want to know. What I will do if I give an antacid, if it's a burning type pain, I will either give it myself and stand there at the bedside and watch the patient and ask them a minute or two later how they feel, or I will tell the patient, okay, the nurse is going to come in a while, give you some white stuff to drink. I want you to look at the clock over there and be aware 2 minutes later, do you have pain or not? And when I come back 10 minutes later and ask them, again, if that pain goes away, you cannot count on that, but it is somewhat evidence that maybe it's esophageal. But anything lower than a minute or two, just throw out the data. It's irrelevant. Let's go on to the ECG. Now, I'm going to just very briefly mention this because obviously Bill Reddy just gave us an excellent talk on ECGs. But you have to look very closely. And as was apparent in the last talk, there can be very subtle differences here. And you know that what you need to do is compare. I'm astonished when I review a case and the ECG is normal, but maybe there's a little, ST variation or something like Bill talked about. And the doctor didn't go back in the past chart to compare it with the prior ECG. And certainly with continuing serial ECGs, if there's any question. I'm always amazed when doctors have not done that, and yet we do see that in litigation. So the only thing I'll say about that is compare. If there's an old ECG in the chart, even if it looks normal to you, compare it to the last one if you can pull it up. And of course, if there's any question, you need to get serial ECGs, obviously. Now, another common mistake is you get an ECG, you order it, pain's going away, ECG doesn't show anything, and that's fine. But if the patient gets pain again, even if you're getting, let's say, the ECG every 20 minutes or every hour, whatever it may be, let your nurses know that if that patient develops pain again, snap that cardiogram right at that point and make sure that you capture that to see if there is any acute ischemic change during that time. Cardiac markers, these have been changing with time, as we all know. Many of us who are older have used, SGOT and CPK and things like that, and we've seen a very gratifying evolution in our refinement of our cardiac markers. Whether it's STEMI, non-STEMI, unstable angina, initial labs, as you know, can always be negative initially. And so we want to obtain serial markers over time. Now, there are many protocols, 1 hour, 2 hour, 3 hour, 6 hour, protocols in an observation center. Lots of variation, lots of different protocols. And there are different markers that we can get now in 2020. Be aware that you can't compare them. If you get a point of care marker, you can't compare that value to the standard lab troponin, and you can't compare that to the high sensitivity troponin. What you want to compare is within each of these categories, if you're using them, is there a change? And of course, now there's no excuse for any hospital not having stat high sensitivity troponins available to us. And if you are in a hospital, certainly in the US and hopefully elsewhere, if you are in a hospital that doesn't give you high sensitivity troponin, you've really got to press for that. And if the serial markers are still normal, look for a delta, look for a rising level, even within that normal range. Let's say, an hour or so later, whatever, but it still hasn't passed the threshold for abnormality. Look for a rising level. And if it's still rising, you want to keep going and keep getting serial markers. Now, just last month in the Annals of Emergency Medicine, Bang and colleagues published yet one more 1-hour algorithm. And if you look at the references in that article from last month's Annals, there are a number of studies that have been published about 1 hour, 2 hour, 3 hour algorithms for repeating your ECGs and your high sensitivity troponins. And depends on what your hospital uses, but it's not a bad idea for you and your colleagues to develop with a cardiologist an algorithm. Now, the thing with all of these algorithms and various types of quote rules, and I hate that term rules, because what does a rule mean? You have to follow it. And as has been said earlier today, no, there's a lot of room for variation with your individual patient. Even if a patient does not meet the criteria of a rule for whatever you're looking at, they still may have that problem. But these, I think, should be really called guidelines, whatever. But there are a number of protocols in the literature that you can use, and you and your colleagues, it's not a bad idea to have one or more of these available to you. Now, the introduction of high sensitivity troponin has really raised some very interesting questions, because when we have looked at unstable angina over time, a very large proportion have in fact developed over that 1 to maybe 3 hours, have developed an abnormal high sensitivity troponin, whereas their normal standard troponin was still in the normal range. And so what it is, that has raised the question is there really such a thing as unstable angina? It may well be that the majority of patients with, quote, unstable angina, in fact, are infarcting, not picked up by standard troponin, but picked up now by high sensitivity troponin. And it raises the question of whether unstable angina really exists. Now, we're not talking about somebody that, has exercise-related angina and, is stable, but patients that come in to the emergency department with chest pain, even if they have a history of angina in the past, what happened today? Why did they come in to see you today when they carry around a little nitro spray and they sometimes have chest pain? What is different about today? Now, we've defined that as unstable angina. It may be that with high sensitivity troponin and serial studies looking at crossing the threshold for abnormal or just a delta change, a rising troponin, that many of these may in fact be infarcts. So be aware of that. We don't miss MI, but we have missed a fair number of unstable angina that progress to either MI or some other major adverse cardiac event. Pain is resolved. The former studies were negative, but hopefully now with high sensitivity troponins, that may not be the case. And if we use that in various scores, as was talked about before, the heart score, et cetera, it may be that missed MI would be a historical term. Now, this is somewhat analogous to the concept of TIA among stroke neurologists. Now, with our increasingly sensitive diagnostic modalities for stroke, we are seeing that a lot of patients that we had previously diagnosed as having a TIA, in fact, are infarcting brain. And so the concept of unstable angina and the concept of transient ischemic attack both may be outmoded and inaccurate diagnoses. Be interesting to see what our definitions evolve to over the next year or two. Well, what about differential diagnosis? This is, of course, really what we're doing, isn't it? It's what we have a patient with chest pain or whatever, and we want to say, is it ACS? Is it dissection, embolus, GI, whatever? Very important point. Now, these things can look very similar, and the symptoms the patient may feel, and even some of our studies may overlap significantly, but we've got to be very careful and look and see if we can distinguish these various potential diagnoses. Chest pain, maybe as many as 10 million emergency department visits per year, according to the article here cited in the Western Journal of Emergency Medicine. We all see chest pain all the time in the emergency departments. One of the most common problems that not only do patients present to the emergency department with, but end up in litigation. So the differential diagnosis, as you see here, is, we all know, and that's why we're discussing it today. And we've had several talks on several of these. So aortic dissection, pulmonary embolus, esophagitis, or other esophageal or GI type etiologies. So let's look at dissection very briefly. Now, we just had this morning an excellent talk by George Willis on dissection, so I'm not going to go into great detail. But again, dissection and ACS can look very, very similar, but something doesn't fit there. So George discussed things like pulse deficit. Yes, check the pulses in all four extremities. Differential blood pressures, I always get differential blood pressure. Now, most of the time you won't see a difference, but if you see a drastically lower BP on the left and versus the right, that raises your suspicion. If they're normal or symmetric, that means nothing. It's not evidence one way or the other. Neurologic symptoms, if you start knocking off some of the blood supply of cord, very common mistake that we see in litigation. Now think about it. Patient comes in with chest pain. Are you going to go send them over to radiology for a good upright PA and lateral? No, you're going to get a portable AP view. And what does that do? The patient's sitting, usually with their hips at 90 degrees, that raises the diaphragm. Since 110% of Americans are overweight, basically, it squishes the lung up. And they can't take as deep a breath. So the mediastinum on a portable AP, anteroposterior projection, will often be a little bit larger. And while it was discussed earlier today that a normal chest X-ray does not rule out dissection, the opposite is also true. At times we see doctors saying, well, I got, the chest X-ray, yeah, the mediastinum is a little bit, but that's just because the patient was sitting up. It was an AP projection, which will make the mediastinum larger than a PA projection. So sometimes we've seen doctors dismiss the widened mediastinum because it was just a portable AP film. So be aware of that as well. A new aortic insufficiency murmur very strongly points towards dissection. Obviously, our bedside ultrasound, perhaps, if not looking at the aorta, at least looking for blood in the pericardial space or a formal echo. And of course, other studies, the chest CT. Very good point was raised earlier that if you get a chest CT for PA, that's a different study than for dissection. And so sometimes we tell the radiologist, I want to look for both. Most of the time, you want to really key in on is your CT either for PE or is it for dissection? And I thought that was an excellent point that was raised earlier. And of course, D-dimer, which is fairly good chance of being elevated into dissection, but not necessarily in ACS. Pulmonary embolus, again, was discussed before. And Mike Weinstock did an excellent talk about that. Pleuritic chest pain, we discussed, is there pain between breaths? Because the pulmonary embolus, it's not likely to hurt much, if any, between breaths. There may be no chest pain with PE. Oxygen saturation may or may not be abnormal. You may hear some scraping in the lungs, maybe. Obviously, there's some ECG changes, which you may or may not see. Elevated D-dimer, pretty good study to get. And of course, PERC and Wells scores. Again, these have been discussed before in the CT angiogram. You can scan the legs, etc. Esophagitis. Now, this is a fairly common co-founder that docs will say, well, I thought it was just the esophagus. I gave her some white stuff and her pain was resolved. Hey, I thought it was, esophagitis. Well, the problem is that the esophagus and the heart lie in the mediastinum, and they can have somewhat similar symptoms. There are several types of esophageal pain or symptoms that can mimic ACS. Esophagitis, that is inflammation of the esophagus, typically causes a burning substernal pain. It's often worse with lying down or bending over and squishing up the, getting some reflux that way. It may be worse with eating, may be relieved by eating. It may well be relieved by antacid. But again, as we said before, you cannot rely on antacid, an antacid trial that really, if it doesn't relieve it in a minute or two, that tells you nothing. Don't use it as evidence to rule out ACS. And if you do get a resolution of the symptoms in a minute or two, that may not mean anything either, but at least slightly points toward esophageal etiology. But the important thing is that cardiac pain can also be just burning. So don't just let that relieve you of your burden for looking further. What about esophageal spasm? This is a real problem because it looks so similar to ACS. But again, you look closely and there may be a difference. But esophageal spasm, excuse me, as opposed to esophagitis, and usually esophageal spasm is a sequela of chronic esophagitis, but spasm in the esophagus may well give a crushing substernal pressure type pain radiating down the left arm. And it's often not relieved by antacids. Well, what does that sound like? Obviously, sounds like what we're worried about. And it's a smooth muscle spasm, and it's often relieved by nitroglycerin. Identical symptoms to ACS. And so a number of patients whom we keep having negative serial studies, but we admit anyway to a short stay unit or whatever to the hospital, a number of these actually in retrospect did have esophageal spasm, but that's not a diagnosis you want to make in the ED. These patients look like ACS, and you've got to act on that. Well, there are two other gastrointestinal, one other gastrointestinal thing, may just be gas. And frankly, I'd like to do a study of the proportion of patients that come in with chest pain, which may or may not be pleuritic, who burp and all of a sudden, after belching, the symptoms are gone. And I'll bet it's a very high proportion. The GI gas, and we already discussed chest wall tenderness, these are diagnoses of exclusion. In a fairly large proportion, I can't give you the percentage, but a fairly large proportion of patients who come in with chest pain, in fact, just have some GI gas or some chest wall discomfort, mostly GI gas. But that's not something you diagnose till you've made sure you've investigated everything else. And even then, that may not be the case. So be careful about these. Don't fall into that trap. But nevertheless, a lot of our patients, in fact, do have that. Documentation is extremely important, and that's been mentioned earlier as well today. And in any case that we see in the emergency department, it is so important. The issue is your chart, should reflect what your thought process is. Document all the pertinent positives and negatives, not a lot of BS, but the pertinent positive or negatives should be in that record. Document your thought process. Why did you send that patient with chest pain home? What were the reasons that you think it's not a cardiac etiology or dissection or embolus or whatever else it may be? In other words, your chart should speak for itself. 3 years from now, when you're sitting in a deposition, you should not have to explain a thing. Your chart should say everything. Sit back, let the chart speak for itself. And in a sense, more importantly, a good plaintiff's attorney does not want to take a case they're likely to lose. And when a good plaintiff's attorney looks at that case and may farm it out to an expert witness, such as myself or others, if that chart is well documented, and you gave good medical care, of course, the chance that that attorney will say, I'm not going to take the case is so much higher than if your charting was, just questionable. The chart is your main defense. I'm not saying put in a lot of nonsense in the chart, but what is pertinent, make sure you have that because it prevents a lot of litigation. Now, we have a lot of algorithms and protocols and various scoring systems. We discussed a number of those today. Again, not a bad idea, but if the patient does not, fall into that worrisome category, that's still you have to use your judgment. That may not, quote, rule out the problem, or the opposite. They may, on that scoring system qualify, but there may be good reasons that they don't. So we discussed that, earlier today. I think Mike Weinstock went into that a fair amount of detail. So again, but it's not a bad idea to have these, and a lot of us use the hard score. Very useful.
Patient has a fractured fibula, given so he can be able to go on tomorrow.
It's going to be so exciting.
That killed him.
And so this brings up the issue of communication, extremely important. And Evie talked about this earlier. You know, a common mistake is to just talk to the patient and not the family. Because if there's any question of cardiac etiology, you don't ever, and again, this was also mentioned earlier, don't tell the patient it's not their heart and the family. Just say, you know, our studies show that it's very unlikely to be your heart, but there's no 100% guarantee. And I use that phrase all the time when I'm talking about abdominal pain, you know, that could be an epi, but it's not really enough to get a CT in this child. Let's say we don't want to irradiate, or may or may not have gotten an ultrasound to look for an epi. But I tell patients, look, the studies we've gotten today, I'm fairly confident that it's not your heart or it's not appendicitis. There's no 100% guarantees. And these things, we are seeing you as a snapshot right now, but illness is a continuum, and it's like a movie. And so if you get it all worse, if there's any change, whatever, I want you to come right back to the emergency department. Otherwise, call your doctor in the morning, that kind of thing. But it's important the patient not understand that you're not giving them a, quote, clean bill of health. Ain't no such thing. And the family. Remember, the patient's dead. They're not going to see you. It's the family. And I consider the family as patients, frankly. I'm sure we've all, you know, had loved ones who are ill, and we are suffering along with them to some extent. And I feel as a doctor, particularly in the emergency department, we don't know these people. They don't know us. I consider, and I try to get my residents to understand, that the family are our patients as well, for emotional support, for whatever, and for educating them, as well as the patient, of course, as to what we are doing and what we are thinking. Now, close follow-up is crucial. Make sure if there's any question of ACS that there's very close follow-up. And again, if the patient's dead, they're not going to see you. It's the family. Disposition. What are we going to do? How can we run into problems with disposition that end up in litigation? Well, obviously, sending the patient home may be a problem, but we have a number of alternatives besides sending the patient back to their home. We can admit them to a 24-hour observation unit, or to a regular floor, but a monitored bed, or the CCU. We have all kinds of options. Obviously, some patients, some protocols, we can, if it's low risk, low suspicion, we can actually get a stress test that day, perhaps. We can get a coronary artery CT. And we haven't really discussed this today, but more and more, we are developing protocols whereby we can, from the emergency department, get a coronary artery CT, perhaps with fractional flow reserve study. And I think this is going to change a lot of how we practice emergency medicine in terms of the possibility of acute ACS. And of course, depending on where we are, we may have to transfer the patient to a higher level of cardiac care center, particularly if we don't have a cath lab. But if we discharge the patient, don't just discharge them. Make arrangements. If there's any question of ACS, make arrangements if you can. Now, 4 in the morning, you may not be able to, but I think it's not a bad idea to contact, share the blame. Call the cardiologist, speak with them, tell them what you have, and if possible, actually schedule that appointment. Don't just give a referral to a cardiologist to the patient. Well, call Dr. Smith and, make an appointment with her, when you can. That ain't good enough. Really try to do as much of that as you can to verbally discuss with the doctor to whom you're referring, even get the appointment scheduled if possible, and make it clear to the patient and family what should trigger the return to the emergency department before they're able to see that consultant in the office. And a very important point generally in all our patients, don't just put in the aftercare instructions, click the thing and on your computer and have the nurse give them. You go in, every single patient, close that encounter. And as an attending, for those of you who are academics, don't just rely on your residents. I believe you should go in and close the encounter with the patient. Summarize what's happening, summarize what your aftercare instructions will be verbally, and make sure the patient understands them. The nurse will then come in later and give them the handout and explain it again. But that's your responsibility, not just for patient care, but to cover your butt and hopefully not get sued. So just a few concluding remarks here. It was alluded to earlier that a commonly published acceptance rate, and in fact, in the latest American College of Emergency Physicians clinical policy on ACS, repeated this, that often it's accepted that we may miss 1 or 2% of patients that will go on to an MI within the next 30 days or something. Yeah, we all make mistakes and we all commit malpractice sometimes, but more importantly, we are not 100% accurate in what we do. And so, yes, we are going to miss these. And so what is an acceptable rate? And often it's published, as I said, that 1 to 2% is often considered. Well, interesting article by Fan in Cardiology asked doctors, this was an international study, and asked doctors, what do you think is an acceptable risk, acceptable rate of patients whom you send out that go on to infarct? And they were asking emergency physicians, and 82%, somewhat over 1,000 patients, I think they were asked, said they were willing to accept a missed rate of 1%. That's even more restrictive than what is generally accepted, 1 to 2%. Think about that. How many chest pain patients did you see yesterday in the ED on your last shift? If you see only 1 chest pain patient per week, and that's a lot less than I see, but let's say if you only see 1 a week, 50 a year, in 2 years, you've seen 100 patients. If you have a 1% quote misdiagnosis, that means every 2 years, you're going to see a chest pain patient that you send home that turns out to have a major adverse cardiac event within the next month or so. Is that acceptable to you? I don't think so. Now, we may not be able to do better than that, but the point of this conference today is to try to educate us into giving the best possible care that we can, mostly for the patient's benefit, but also for our own, so that we do not get sued. Now, if we, as doctors, give the best care that we can and treat our patients humanely and communicate well with the patients and their families, and we document well, the chance of us causing harm to the patient is significantly minimized. That's most important, but also important to us, the chance of us getting sued is minimized as well. And the chance that we will win that lawsuit is significantly maximized. So if we practice good medicine, communicate well, document well, treat the family as patients as well, our patients will do well, we will do well, we'll have a wonderful, rewarding career in emergency medicine, and everything will be wonderful. At any rate, thank you very much. I appreciate being able to talk to you folks, and hopefully this has been a bit helpful to you. Thank you.
Thank you, Michael. That was really interesting. One quick question, just in the interest of time. Any thoughts about troponin I versus troponin T? Because some facilities use one or the other.
Well, there are a number of recent studies published using both rapid high sensitivity troponin I and troponin T. I'm not aware of any significant difference. Before high sensitivity, yes, troponin I seem to be somewhat better, but with high sensitivity, to my understanding, they're pretty much equivalent.
Thank you very much.